Hello, my name is Matt Scanlon, and I've been asked to discuss the topic, the role of QI in patient safety. In preparing for this talk, I began by asking myself, can we use quality improvement to improve patient safety? I thought the answer was a solid maybe. We've had limited success using applications of QI to problems like central line-associated bloodstream infections and other hospital-acquired conditions. But my real concern is not whether there's a role for QI in patient safety. Instead, my concern relates to why the patient safety movement, whether using QI or other tools, has made relatively little progress in the 22 years since the release of the Institute of Medicine's report to Err is Human. Before I address my concern, let's look at some data. First, evidence suggests that there are 200,000 to 400,000 preventable deaths each year due to harm during healthcare. It is this data that led Macri to wrongly conclude that medical errors are the third leading cause of death in the US. Macri was correct about the scope of the problem, but not the cause of the problem. We will visit that issue shortly. What about our success record? Well, here there's little data to go on. This publication by the Agency for Healthcare Research and Quality suggested they saved 8,000 lives over a 3-year period by reducing hospital-acquired conditions. Given a very generous assumption that this savings was true every year since the release of the IOM report, it would only mean that we've had 5.5 million deaths and nearly 60,000 lives saved in that time period. Meanwhile, pediatric data from the Solutions for Patient Safety showed harm reduction to over 11,000 children. However, the number of lives saved versus harmed is unclear. After spending over 20 years formally learning quality improvement, patient safety, and human factors engineering, I believe that one of the primary reasons that the patient safety movement's record is so poor is because healthcare and patient safety are either unaware of or have neglected what I call safety science. That is, there is a large and rich body of knowledge that underlies every other safety program outside of healthcare in other industries that healthcare is not applying. I realize this is also a controversial, if not heretical, statement. So let me make my case with some examples. How many of you have either heard or even said these statements? If so, you've witnessed or demonstrated a fundamental lack of understanding of systems in healthcare. For you see, healthcare is what's called a sociotechnical system. The socio of sociotechnical simply means people. The technical simply means everything that's not human. This means that people are a fundamental and intractable component of sociotechnical systems, particularly that known as healthcare. As a result, it is impossible to have a systems problem or a people problem. Understanding that healthcare is a sociotechnical system is essential to understanding both good and bad outcomes. These papers are only two of multiple that describe the CPPS model, a simple but powerful model of understanding sociotechnical systems as applied to healthcare. Perhaps the worst offender at drawing false distinctions between humans, their errors, and the larger systems they work in are the diagnostic error camp. This group routinely states that there are either the diagnostic errors are either the result of system-driven errors or cognitive errors by humans. For their thinking to be true, some diagnostic errors are explained by failures in technical systems like computer failure. But as they make the distinction between system failings and those of cognitive errors, then the following also must be true. For cognitive errors to occur independent of systems, this would require that providers, like the displayed brains in the picture, make diagnoses without interacting with the larger world around them. By this thinking, pediatric intensivists don't really interact with your world to take histories, perform physical exams, or interpret labs and images, never mind do procedures. Instead, we must reside in some matrix-like vacuum where the patient's history, exam findings, and ancillary data magically appear in our brains, at which point we helplessly then fall prey to cognitive biases. This thinking completely ignores the reality that we work in busy, distracting environments with competing demands, time pressures, and asynchronous data flow. The reality is that both correct and incorrect diagnoses are the reaction of interactions of intractable, complex sociotechnical systems of which people are a fundamental component, and not due to simple cognitive biases. The second explanation for the poor record of patient safety movement is the misguided preoccupation with errors. Macri's mistake was blaming deaths on human errors rather than the real cause, failings of complex systems. None of this is to say that human errors aren't a real phenomena, but the subject is far messier than we would like to believe. Here are two of numerous papers that address the issues with the concept of error. Whether viewed through the lens of history, philosophy, psychology, or engineering, the concept of error is of limited utility. This issue is so problematic, it led one expert to say, error in medicine and the adverse events that may follow are problems of psychology and engineering, not of medicine. Another problem with errors is that there is no gold standard for error detection. This is one of numerous papers that show that the errors we detect or fail to detect depend on the method we chose for detection, as well as the aspect of care being studied. No one method detects all errors. Therefore, if someone claims they know the error rate at their institution, they are simply revealing they do not understand error detection. Instead, we only know the rate of identified or detected errors. Another issue is that we are fundamentally challenged by both hindsight and outcome bias in attribution of errors and blame. Kaplan's work in the bottom left corner shows that if there is a bad outcome, we will find people at fault despite the fact that they met the standard of care. Then there's the problem that the root cause analysis literature demonstrates that when we investigate an adverse event, the investigation almost always stops as soon as we find someone who made a mistake. We use the mistake to explain away the event and sometimes punish the person as if that actually prevented future problems. Instead, the literature shows that focusing on errors is short-sighted, results in wrongful punishment, and doesn't actually make anything safer. This led Cook and Nemeth to state that if your investigation concludes in the finding that the cause of the accident is human error, the investigation is fatally and fundamentally flawed. The philosopher Santayana would be dismayed by patient safety's inability to learn from history. In 1947, Fitz and Joan released a landmark study of 460 plane crashes that had been blamed on pilot error. After their investigation, they concluded that the pilot error was not a random phenomenon. Instead, it was understandable, regular, and actually predictable as the result of the design of the cockpit and its tools. In the same way that human error is just a label for the limits of, in the same way, human error in medicine is just a label for the limits of human perception, data processing, and action in a complex and dynamic work environment. To err is human precisely because of our inherent cognitive and physical limitations. I know that some of you may be balking the analogy between aviation and medicine. I agree, medicine is far more complex. But let me give you a medical example of the poorly designed cockpit, the electronic health record. After safely providing anesthesia to a patient, an anesthesiologist wanted to administer some morphine for pain relief to the patient while they were in the recovery room. Like you know, dosing of medications in pediatrics is based on patient weight. So the doctor initially ordered a small dose of 0.05 milligrams per kilogram. However, the resultant dose, 0.98 milligrams, was more than they wanted to give. And so they changed the order, instead ordering 0.75 milligrams of morphine. What they failed to recognize is that the EHR defaulted the units to weight-based rather than milligrams or forcing some choice. This resulted in a prescribed dose of 14.5 milligrams after automatic dose rounding. The anesthesiologist claimed they heard no alert, but after investigation, alerts were found. Instead, what had happened was what's the phenomenon called desensitization due to the sheer amount of alerts in the system. This desensitization is commonly referred to as alert fatigue. In fact, in the second full month of use of this commercially available and award-winning electronic health record, over 106,000 medication orders had been placed with a generation of over 99,000 alerts for a rate of alert of 0.94 alert per order. And yet we blame the anesthesiologist. Santayana would also be appalled that we ignored the lesson of safety in anesthesia. In the 1980s, roughly 6,000 patients a year, known patients a year, were being killed or harmed during anesthetics. In response, engineers and psychologists were brought in to study what was going wrong. They found fundamental issues with the design of the machines used to deliver anesthetics. Additionally, they discovered that universal connectors were used for gases like oxygen and nitrous, resulting in disastrous mix-ups of the gases and harms. While the work of Jeff Cooper and others made anesthesia demonstrably safer through redesign, patient safety has learned little of this chapter. Perhaps most damning is the tale told in this chapter of this displayed book. In it, Richard Cook relates how a group of safety experts proposed to healthcare leaders that healthcare leaders learn from the mistakes of other industries before them and not focus on human error. Their concern was that the risk was that patient safety movement would just become another attack on human error, thus delaying any real progress on safety for over a decade. Unfortunately, it's been over 2 decades and we still haven't learned better. There are other patient safety sacred cows that would be best killed off. The Swiss cheese model is attractive in its simplicity. However, besides the fact that it is routinely mispresented by safety experts, patient safety experts, it's been called unscientific and simplistic, reductionist and linear, and preoccupied with causality rather than complexity. More importantly, there's actually more robust models for viewing complex systems like healthcare. Meanwhile, here are just 2 of numerous papers critiquing root cause analysis as it's performed in healthcare. In fact, healthcare's deficiencies investigation of events are actually the subject of papers and editorials. Like the fact that there are numerous models beyond the Swiss cheese model, there are numerous investigation techniques beyond root cause analysis that would actually yield more value. These include what's called the Human Factors Analysis and Classification System, or HFACS, AXI maps, which are great for revealing the contribution of regulatory and organizational decision to events, and various hazard analysis techniques. In addition to Pirelli's excellent critique of root cause analysis, the BMJ Quality and Safety Journal had multiple other critiques of topics near and dear to patient safety and quality improvement's heart. But there's more issues that patient safety ignores than I have actual time to cover. So let me touch on just a few more briefly, some which are pertinent to QI. First is the fact that healthcare almost completely ignores the concept of hazards with the exception of occupational safety. Yet identification and the control of hazards is central to safety programs in every other industry. The displayed textbook discusses hazard control for chapter after chapter as it relates to occupational safety in healthcare, yet their sole chapter on patient safety goes down the rabbit hole of human error. Other topics of importance is the issue of standardization versus adaptation. While the quality improvement movie holds that standardization is one of its goals, safety science, particularly resilience engineering and what's called safety 2, argued that safety is not created by standardization, but rather by people adapting to our complex, dynamic, and poorly designed systems of delivery. In fact, mindless or careless standardization will actually impair adaptation and harm safety. A second issue is the almost religious-like approach many QI programs adopt to interventions. Whether it be Lean, Six Sigma, or Rapid Cycle Improvement, QI programs seem to have a single set of tools they apply to every problem, regardless of its nature. Yet the role of a good physician is to diagnose their patient before treating and then match the treatment to the patient. Unlike QI practitioners, when I talk to a human factors engineer and ask them how to solve a problem, they always give the same answer. I would need to go study the problem before I could begin to fix it. Finally, there's this subject of archetypes of work, 2 of which include work as imagined and work as done, which are provocative explanations for why much of our improvement work may fail or actually make things worse. In closing, QI may have some future role in enhancing patient safety. But after over 20 years of doing the same thing over and over again, I would argue it's time to look outside and beyond patient safety to the domains of safety science and human factors engineering. Thank you.